Hello, hello. Welcome to Healthy Perspectives, a podcast that takes on current cultural and social issues through a clinical lens. Hello, hello. All right. Welcome back. Thank you so much for joining us. As always, we appreciate your time. And with today's podcast, I want to hit on something that is a little bit challenging because if I'm being real honest, I love what I do. And criticizing my profession is not an easy thing because I really want my profession to matter. And this isn't intended to be a slam on the counseling profession as a whole. This is a slam on how it can go south. Look, anywhere you go, no matter what your profession, no matter what you plan to do or are doing, there are going to be good features and bad features to what you do. You want to work in food services, you're going to smell like grease and oil. I mean, it's just what happens. And, the combination of all the different foods. You're going to work in the military. There's good aspects and not so good aspects. You're fighting for something that matters, freedom, but you will never get the respect you deserve. That's just the way it works. And then there are people within every profession that are flippantastic, just great, high quality human beings. One of the things I used to say about the military was, would you rather have somebody who is a high quality human being put in those really tough, challenging, awkward positions of having to decide lives? Or would you rather it be like, the scum of the earth? I would prefer it be high quality human beings, because at least then some of the time, if not most of the time, you're going to get good judgment, good decision making. Like, I don't need to take this life in order for my platoon to live, or I do. And you get really good sound judgment with good high quality people. At least you should get better high quality judgment from good high quality people. Well, I want to talk about the lowest intervention model. So in the clinical world, just like in the medical world, we are supposed to do the lowest level intervention. In other words, if you were going to go in and have a surgery, it's not because it's fun. You go in and you have a surgery because it's necessary. If it's not necessary, then you should not do the surgery. Except the medical world has gotten away from that. How do I know? Well, it's pretty obvious. As soon as we started to do more repair work in terms of eye appeal, plastic surgery, Botox, stuff like this, we got away from is it clinically necessary? And we got into the business, is it clinically profitable? Well, unfortunately, the mental health world is capable of going down that same unhealthy path. And they do. Does that mean there aren't amazing doctors and surgeons and all of that kind of stuff in the world? Nope. It does not mean that. Does it mean that there are some that are unhealthy and contributing to unhealthy practices? 100% it means that. And so how do you know the difference? Well, in the mental health world, one of the things that we are taught, and I'm going to teach it to you today, if you are so inclined to learn something new and helpful, the lowest intervention model. What that means is that I will provide the lowest level of care possible to create the change necessary. There's a lot of judgment that goes into that. I have to be able to simultaneously assess levels of care and necessity. So here we have the problem. But before we go into that, The intervention model is designed to do three things as I can tell. They're all ethical principles. Maximize autonomy, meaning you have the decision, the ability to make your decision, not my decision, not somebody else's decision, but your own decision. Now, autonomy gets really tricky when we're talking about children. You're going to hear where this is going as we go. Number two, it's designed to maximize justice. And remember, in the clinical world, justice is not about right and wrong. It's about treating you uniquely as you are, which in previous podcasts, you've heard me talk about the importance of not as I want you to be, or not even necessarily as you want to be. And the third thing that it's the lowest intervention model is designed to do is to minimize harm. If I act in your world and cause you harm, I fail you. And truth be told, we act in each other's worlds all the time, every day, and not always for the better. Sometimes we create discomfort. Discomfort doesn't mean bad, doesn't mean unhealthy necessarily. But if we push that discomfort into a realm where you fall off of the cliff, if I keep pushing and pushing and pushing and you fall off the cliff, then I have done harm. And the lowest intervention model prevents me from pushing you off the cliff. It still requires judgment. And there are therapists that are really good with judgment, and there are therapists who are not as good at making those judgments. But a lot of that is also on you. If you're a client of a counselor, your job is to tell them if you're feeling those really dark, invasive thoughts, self-harm, suicidal ideation, homicidal ideation, stuff like that. So let's take a look at this lowest intervention model when it comes to something like addiction. I'm going to give you a few examples of the lowest intervention model. One of them is going to be glaringly different than all the rest, which points to a problem I have with my profession. You'll understand as we go. In the treatment of addiction, I'm going to give you a list of options. These are treatment options, okay? Medical detox. Does that seem like the lowest intervention? No. How about inpatient rehab? Also not the lowest. How about outpatient rehab? That's definitely lower than the other two so far. How about court-ordered rehab? That's a loss of autonomy. So that would not be the lowest level. How about a sober living program? How about an AA or NA group? Like those are lower levels, but the sober living program would be a higher level. Pretty simple to see that, I would think, right? I'm maximizing your autonomy. I'm maximizing you being treated uniquely as you are. All of these things are considerations. And then you look at children and drug addiction. And all of a sudden it gets a little bit more tricky because a child doing drugs, somebody under the age of 18, well, that's also illegal, which means their risk of harm is actually higher. It sounds silly because their accountability would be lower, but their risk of harm is higher. Getting addicted early often leads to higher prevalence of addiction later. Not always, but oftentimes. And so you consider that autonomy plus how much autonomy does a child have? Not nearly as much as an adult. So now you can see we're starting to weigh all these different things, but it's on a spectrum. So how about depression? It's the same thing, folks. If I'm treating depression, it's the same thing. Inpatient all the way to outpatient. medication all the way to education, things like types of treatment, CBT, that's modestly invasive, but not super invasive, but narrative reframing, not really invasive. It gives you the option of saying, does this other narrative possibly fit? Right. And so when we're looking at these psychotherapeutic interventions, these different types of interventions, as a counselor, I'm always asking, what's the lowest level of intervention that I can implement that may create success? And I'm going with that model. But then we enter the realm of what we call gender dysphoria. And all of a sudden, the clinical world is taught affirm their gender identity. That's interesting. Is that the lowest level of care possible? Well, if I affirm your identity, then I have to treat you as you're wanting to be treated, as opposed to how you are. I don't know if you noticed, but that goes against the clinical requirements of justice. I can't treat you how you want to be if you're telling me you're a bird, but you're actually a fish. That would be unethical. Ooh. So what do I do with that? Well, are there any laws that require me to treat you like a bird because you say you're a bird? Well, right now, I have no laws that require that I treat you as you want to be treated. So I default to the ethics. Now, does that mean I'm going to discriminate against you? Absolutely not. It simply means that in this, when I look at the highest level of care, I am going to go with somebody who's transitioning, having surgery, because dysphoria, by the way, I'm gonna clear a little something up with dysphoria and transvestic disorder. Very different, very different. Okay, but I'll get to that in a minute. Dysphoria, it's that sense that they don't belong in their body. That's what the gender dysphoria is. It means I don't belong in the body that I have. Except we don't have a way to give you a new body. So here enters the problem. I can't ethically treat you as if you're something you're not. Now, I understand gender dysphoria. I have worked with many people who struggle with gender dysphoria. It's a real thing. And it doesn't mean that they're a boy because they say they're a boy, or they're a girl because they say they're a girl. It means they don't feel comfortable in their body. Okay, rewind your clock. I don't care how old you are. Go back to between 10 and 15 years old and tell me, did you feel comfortable in your body the entire 5-year span from 10 years old to 15 years old? No. 100% of you will say no. If I did a poll, I would, well, okay, a 99% of you. Why? Because there's going to be that one person who is got a facade, and they just want to destroy the the data, and so they're going to throw out the, oh yeah, well, I always felt perfect exactly how I was, and you're full of crap. But that's okay. I'll give you that 1%. All right. The rest of you had times then, and probably even times now, where you didn't feel comfortable in your body. Maybe I'm a little too big here. I wish I had a little more of this. My muscles could be a little bit bigger if I was a little faster. Does that mean you have gender dysphoria because you're uncomfortable in your body? No. What I'm simply telling you is that there are periods in our life where we experience the desire to be something we are not. All of us experience that. So technically, I could diagnose every single person I encounter and then treat it, the diagnosis, not the person, which is where, in many cases, my profession has gone off the rails. Now, I think there are great therapists who don't go off the rails. I've met some, I've met many. And I've also met those who have gone off the rails. Why do I tell you this? I tell you this because it's easy to do, folks. I don't hate the ones that have gone off the rails. I just think they don't understand what they're doing. They need more education. They need better understanding. And oftentimes, unfortunately, the higher our education, the more we feel like we're right, that we know what we're talking about. I'm susceptible to that. I've talked about that in other podcasts. I've gone with the elitist mentality stuff. It's very easy to venture down that path. And the reality is, everybody hurts when we do that. So, to some degree, I'm going after my own profession today. Not because I don't love what I get the opportunity to do, as I do love it, but precisely because of that love. To say, hey, if you're a therapist out there, you're a counselor, follow your laws and your ethics. Follow them. If you can't name all the ethics, go get an education on it. Autonomy, non-maleficence, beneficence, justice, fidelity, and veracity. If you don't understand those 6 concepts thoroughly, go get training on it. Because unfortunately, we in the profession, by affirming what people want to be as opposed to what they are creating injustice, harm, and we're taking away autonomy. How do I know that? Because promoting things in any way, promoting things that are a higher level of care than is necessary is taking away autonomy. It's taking away that decision-making ability of the person in front of you. And by the way, as soon as you start doing that, they're going to turn to you and say, what's my next decision? Because it's easier to follow directions than have autonomy and make decisions. And most people, especially people who are wounded, are looking for that direction. I'm not saying you can't provide direction and instruction. That higher level of care is there for a reason, but you only go to the lowest level of care necessary for growth and shifting. You don't jump to the front of the line and go to the highest level of care because I'm the expert in the room. Don't do that. Don't fall for that. I'm talking a lot to the therapists, the counselors out there in the world. My hope is you send this to every counselor you possibly can because our profession needs this shift. But I'm also saying this because if you seek counseling and they're telling you what you have to do, that's not correct. It's not correct. Autonomy means we make recommendations, but you make decisions. If I tell you, you do not need surgery, I'm not a doctor, I can't tell you that, but let's say I did. It's a recommendation. You make the decision. If you decide that's a great recommendation, I think I want to follow that. That's your decision. I did say I would clear something up. Gender dysphoria and transvestic disorder are very, very different. I told you gender dysphoria is about feeling like one's body is kind of not their own body, right? Or not comfortable with their identity in their body. That's why we call it gender dysphoria. It's because it's this almost like this cloud that sets on us and tells us we're not who we think we are, or vice versa. We are different than we think we are. Okay. Transvestic disorder is really, it falls into a completely different category of disorders. It doesn't even fall into the same category as gender dysphoria. Transvestic disorder is about dressing up as the opposite sex. This is your Miss Doubtfire or Mrs. Doubtfire example, right? In that particular situation, he didn't want to dress up as a female, but he did it because it got him some gains. But the truth is, most people with transvestic disorder have a little bit of that histrionic tendency in them as well. For those who don't know it, go look it up. I've done podcasts on that as well. But it really is just about dressing up as the opposite gender as a means of getting attention and feeling comfortable. Totally different than gender dysphoria. I hope that clears up that little. Now, a lot of people think that trans means that they have gender dysphoria. Not necessarily. It might. There are some comorbidity there, yeah, but it's not a 1-for-1. Some people just like dressing up as the opposite gender. That's a very different thing than gender dysphoria. Okay. I hope that clears up some of these things. Again, my emphasis is lowest level of care necessary to make the growth begin. The lowest level of care. That's what I'm hoping you're taking away from this. I gave you a bunch of examples, and I even gave you an example where oftentimes we are encouraged to jump to higher levels of care when it's not necessary. That inpatient instead of outpatient, and so it goes. I hope this helps clear up some of that confusion. Please send me emails, feedback. I'd love to hear from you. I appreciate your time. As always, please like, subscribe, hit the little bell on Spotify, all those good things. Follow me on multiple platforms. It really does help. Thank you so much for joining us, and I hope you have a wonderful day. Hey, everybody. Thanks for listening. We appreciate our audience a lot, so we give you some simple ways to track us down. Please like, subscribe, and follow all the podcasts on different platforms, but you can also email us at healthyperspectives@protonmail.com, or you can check out our website at healthy-perspectives.com/podcast. It's a backward slash. So if you want to go to our landing page, if you go to healthy-perspectives.com, you'll still find us. You just got to click on the podcast button. Thank you so much.